Good evening. Thank you very much for still being here and giving me the opportunity to present the eHealth, the Swiss approach. You will be better able to follow my presentation if you understand something about Swiss politics, and Swiss politics is explained best, I think so, with the following joke. You know, in Switzerland we have a federation of 26 cantons, and two little boys have been discussing how it comes that women get pregnant and give birth to children. And one of the boys has said, I don't know exactly, but one thing I'm sure, in every canton it's different. So that's the way how Swiss politics works. The starting point of our eHealth strategy is depicted here. You see here a patient who becomes sick. He goes probably through telemedicine. The call center tells him to fetch some medicine in the pharmacy. Finally, he ends up to the doctor, goes to a specialist hospital. He needs rehabilitation and perhaps home care. And how do the stakeholders now interact, or how they communicate? It's mainly by mail, phone, fax, letter. You will agree that that is not interoperability at its best. It needs improvement, and that was the starting point for our eHealth strategy. The electronic health record in Switzerland has the aim of providing a virtual place where all documents of a patient are available. And let's again look to the situation. This patient may, in this example, having also a immunization passport, which he adds to his collection of documents. He has recently been to a hospital where the report is transmitted to this place, and also the e-medication is there. And at the moment where this patient needs to go to a doctor, he allows this doctor to fetch all this document and to import them in his electronic system, and to be informed about the former history of the patient. That's the ID. Now, what is different compared with the past? New is digital instead of fax and mail, publish instead of sending from A to B. We clearly don't support the directional communication. The electronic health record has the intention of providing an indirect communication, which makes available all documents needed by whoever it may concern. And what is very important in our strategy is that the patient can see their record and give access rights, or they can also deny access rights. The patient is in the center of all this movement we bring forward here. Now, what I've told you in the joke about the cantons, the problem, or perhaps the chance in Switzerland, is that the cantons are responsible for health care. And this means nothing else that in Switzerland we have about 26 different health care systems, and it's not so easy to bring them all under one hut. Some figures: more than 300 hospitals, public and private ones, more than 10,000 private medical practices, more than 500 ambulatory home care centers, more than 1,700 private pharmacies, more than 60 private insurance companies. 26 cantons are part-time payers and hospital owners, and there's a mandatory basic health insurance, but this is provided by private companies, and also the private extensions are provided by private healthcare insurance companies. So it's heterogeneous and with a high diversity in terms of organization, but especially in terms of IT system. And the danger is big that you end up like these bridge builders when bringing forward eHealth in Switzerland. So what was our way to go? We decided to make a framework to have legal support from the national level. A federal level was brought forward, a common legal framework for standards and infrastructure. And on the other hand, of course, we have still at the cantonal level established these different healthcare systems and which act more or less independently in the cantons or in the regions. That was or is still a major challenge for eHealth in a federated system. Some of these challenges are: we have a major goal to keep up a decentralized system, because something which is centralized politically, it's simply not feasible in Switzerland. We do not have a central patient registry. We will work with a federation of master patient index. We have no central document registry. Instead, we have decentralized registries and repositories which we bring together in a federation. And the most important things for political acceptance is the patient self-determination to which information is available for whom. And this is made on a fine granular access management. I show you how this... wrong button. Show you how this works later. Important to know is that the electronic health record in Switzerland is designed as a secondary system. We will not link primary hospital systems together. Instead, the so-called communities are required to have secondary repositories and to copy all relevant data of their primary systems in this secondary systems. We opt for strong regulation also in terms of technical standards. We adopt CDA documents. The reason why we are not yet on fire, as Charles has presented, is because our movement, you will see the timetable started long before fire was a subject of interest. But I can assure you that if I change my hat and speak with the hat of a member of the boards of eHealth 7 user group Switzerland, we are definitely on fire. And I think sooner or later fire will also find its way in our national electronic health record. But at the current state of development, we are based on CDA. Important is to note that it's only for documents. We don't go for single data like some portable apps do. They measure heart frequency, they measure oxygen saturation and so on. We act on the level of documents, and once again, for the third time, it's totally patient-owned and controlled. So our policy is to link regional projects which are already emerging, to link them together under national rules. We do this by means of so-called communities, which will be brought forward by private activity. It's not regulated who will form and who will act as a community. But what is strongly regulated is that they have to be certified. Only certified communities have the right to enter the circle of trust and to participate on this electronic health record. And all this is guaranteed by a national law, law. So this law called Bundesgesetz über das elektronische Patientendossier was a very long time, really very long time subject to political discussion, but finally it was accepted and the Council of States with 45-0 votes, and the National Council, as those who are familiar with politics, you may know that we have this that we have two councils in Switzerland. The National Council adopted it with 189 to 5 votes. So at the end of all political discussions, there was a really high political acceptance. According to the law, which is valid now by 2017, we have defined a transition period because, of course, the oldest hospital cannot switch from one day to another to such an electronic solution. It's for hospitals, they have a time of 3 years, and for nursing home, 5 years. Outpatient care is voluntary. Now, you may ask what happens if they don't switch to this system in 3 years. They lose the right to be paid. It's a very strong incentive. And why? You may argue that outpatient care, that this is voluntary, is not the lightest of ideas. I mean, this is right. The problem is we're in a basic democracy, and if one major player, in this case the doctors, do not want something, you will never get it realized. So, I mean, we do what is possible, and it's not always the best solution. It's mostly the possible solution, and this was our political, what was the end of the political fight. We ended like this. Another thing which is voluntary is that it's voluntary for citizens and patients. That's, of course, I think everybody agrees that's the right decision. You could never make such a project mandatory for the citizens. So I promise that I give you some insight in the management of access rights. I promise to give you some insight in management of access rights. You see here that it's on a fine granular level. The patient can say, I give access rights to this doctor and to this doctor, and to the other doctor I don't give the access right, and it's not on the level of some cloudy system where we just give access rights to hospital this and other, and nobody knows who is working there. So it's really fine granular, and the patient know which persons have the access right and which persons do not have the access right. So, our technical standards, we are strongly based by IHE. Those who are familiar with IHE, it's in fact an XDS architecture. Under this XDS architecture, as already said, all documents, or most documents, or in the future, hopefully all documents will be based on CDA. Of course, at the present state of development, we also accept PDF because not every hospital has the possibilities to produce structured reports, etc. For semantic interoperability, our main instrument is SNOMED CT. For laboratory labs results, of course, LOINCS, and for security we base on OASIS. Switzerland is full member by SNOMED CT for now roughly more than 1 year. We use it primarily for metadata, but of course we will use it for all clinical data which shall be coded, and the future usage is planned that we use SNOMED CD as the reference terminology for different knowledge domain. I mean, it is our goal to have SNOMED City widespread, but of course it's not always possible. I don't think that you can change the lab domain from LOINC to SNOMED, because LOINC is there a well-established standard. Okay, we have many specifications. We have strongly regulated electronic health record project in terms of certification for processes, certification for technology, and certification for organization. What else? The problem is, I will show it here, we have additional challenges. No concepts are presently available for patient-generated data with mobile devices and apps. These needs further development. And one of our main problems we have to solve is finding the right balance for IT security. You have learned in approximately 1 hour before I speak here the challenges of cyber threats, and of course the best security you have when you switch all computers off, but then you cannot work, and it's not yet clear what is the right balance between cumbersome work with the electronic health record on one hand and with enough data protection. Finally, sustainable financing. This is not yet clear. It's still open if these communities will give such services for free, or if they will be combined with a fee. We will look how this will emerge. What is open too is future support of process. Those familiar with IAG, there is a XDV profile who deals with that. I think sooner or later we will integrate also process support in our electronic health record. That's our goal, finally, that the entry for eHealth with the help of eHealth works much faster and quicker when you're a patient who needs care than compared to the situation where you don't have any eHealth records. Thank you very much.